Welcome to our first video on gallstone-related diseases. Let's begin. The gallstone-related diseases are cholelithiasis, cholecystitis, cholelithiasis, and acute cholangitis. The latter two will be covered in the next lecture. We'll begin by discussing cholelithiasis. For this topic, we'll be covering the definition, pathophysiology, risk factors that lead to the disease, clinical features, diagnosis, and management. First, let's define a few terms related to gallstone disease. Cholelithiasis is the presence of one or more calculi in the gallbladder, regardless of the presence of symptoms. Calculi in the gallbladder can be formed due to various reasons and also have varying compositions. Asymptomatic cholelithiasis occurs when stones are present in the gallbladder, but the stones do not cause any clinical symptoms. These patients are identified incidentally during routine examinations. Symptomatic cholelithiasis, as the name indicates, is a clinical diagnosis that occurs when the stones in the gallbladder cause symptoms such as biliary colic. It can be called uncomplicated if it is not associated with signs and symptoms of cholecystitis, cholangitis, or cholelithiasis, which will be discussed later. Stones in the gallbladder occur for different reasons. Let's look at how the different types of stones form within the gallbladder. Cholesterol stones are the most common type of stone. They're formed due to dysregulated cholesterol metabolism, which leads to increased cholesterol saturation within the bile and a concurrent decrease in bile salt levels. This oversaturation leads to precipitation of cholesterol and calcium as stones. Another type of stone called black pigment stones occur when there is excessive hemolysis, which leads to an increase in serum levels of unconjugated bilirubin, which increases the release of bilirubin within bile and leads to precipitation as stones. Brown stones are mainly due to biliary infection with organisms that produce beta-glucuronidase, which leads to increased hydrolysis of conjugated bilirubin. Consequently, the increased concentration causes precipitation of cholesterol, calcium carbonate, and calcium bilirubinate as brown stones. Before I go any further, I'd like to mention this image was contributed by Amboss. Thanks to our partnership with Amboss, I can highlight several important features of gallstones. In this illustration, you can see the individual processes that lead to different types of gallstones, as we discussed on the previous slides. Feel free to pause the video here to review the pathophysiology with this image before moving on to the risk factors for cholelithiasis. The risk factors for cholesterol stones are the famous 4 F's, which are fat, female, 40, and fertile. These indicate obesity, female gender, age, and parity. Additionally, malabsorption and total parenteral nutrition are risk factors for stone formation. TPN is a risk factor for gallstone formation due to biliary stasis related to the absence of enteral stimulation. Risk factors for black pigment stones are any condition that leads to chronic hemolysis. The major risk factors for brown pigment stones are bacterial or parasitic infections of the biliary tract. Cholelithiasis usually has no symptoms, with stones being found on routine investigation or scans for another disease. When symptomatic, cholelithiasis presents with biliary colic, which is a dull and aching right upper quadrant pain that occurs postprandially, lasting less than 6 hours. Pain occurs postprandially due to the production of cholecystokinin, which leads to gallbladder contraction of the stone against the cystic duct. The pain may radiate to the epigastrium, right shoulder, which is known as Kerr's sign, and to the back. Other non-specific symptoms may include nausea, vomiting, dyspepsia, or bloating. Cholelithiasis is usually present in 10 to 20% of the adult population and without symptoms, does not require additional diagnostic measures. If the patient experiences any of the previously mentioned symptoms, the best initial diagnostic study is a right upper quadrant ultrasound. However, if a transabdominal is non-diagnostic and there is a high clinical suspicion for gallstones, then an endoscopic ultrasound can be performed. Ultrasound findings suggestive of cholelithiasis are the presence of echogenic foci within the gallbladder, a posterior acoustic shadow, and the presence of biliary sludge. On ultrasound, biliary sludge appears as an area with no acoustic shadow that moves as the patient changes position. Lab findings are usually normal in uncomplicated cholelithiasis. This is an ultrasound image showing gallstones. Notice the posterior acoustic shadow that lies beneath the echogenic stone. Treatment of cholelithiasis depends on if the patient is symptomatic. Asymptomatic patients do not require any interventions and can be advised on lifestyle modifications to reduce risk factors. Patients with symptomatic, uncomplicated cholelithiasis can be managed acutely with an NPO diet, analgesics such as NSAIDs or opioids for pain, and antiemetics for nausea. As soon as the episode resolves, the patient can be scheduled for an elective cholecystectomy to prevent future episodes and complications. Next, we'll be discussing acute cholecystitis. In this topic, we'll be covering definition, pathophysiology, risk factors, clinical features, diagnosis, management, and complications. Cholecystitis is defined as inflammation of the gallbladder either due to blockage by a stone, blockage by biliary sludge, or due to infection with gas-forming bacteria. Blockage of the cystic duct by a stone is known as Acalculous Cholecystitis. Infection of the gallbladder with gas-forming bacteria leading to inflammation is known as emphysematous cholecystitis. Cholecystitis can have various different pathomechanisms based on the etiology. One of the most common causes of cholecystitis is Cholelithiasis that leads to obstruction of the cystic duct. This then leads to gallbladder distension due to congestion, which triggers an inflammatory response that is accentuated by proliferation of bacteria. Acalculous cholecystitis can arise in the absence of gallstones and is caused by biliary stasis and gallbladder hypoperfusion that can then elicit an inflammatory cascade of reactions. Finally, if the gallbladder or biliary tract gets infected with gas-forming bacteria, such as Clostridium species or E. coli, then this can also trigger inflammation within the gallbladder. However, these gas-forming bacteria can also lead to the presence of air within the gallbladder wall as well, leading to what is known as emphysematous cholecystitis. The risk factors for calculous cholecystitis are similar to the risk factors for cholelithiasis because both pathologies depend on gallstone formation. Additional risk factors that can predispose to emphysematous cholecystitis are those that can cause infection, such as an immunocompromised state and infection with gas-forming bacteria. Major gas-forming bacteria that have been implicated in this disease are Clostridium species, E. coli, Klebsiella species, and anaerobic streptococci. Let's now look at the clinical features of cholecystitis. In cholecystitis, right upper quadrant pain may be prolonged and severe with possible radiation to the right scapula. Patients may also exhibit fever, malaise, anorexia, nausea, and vomiting. Guarding, which is involuntary flexion of the abdominal wall musculature due to pain with palpation, can also be due to the presence of an inflamed gallbladder. Additionally, due to contact with the diaphragm when the gallbladder is deeply palpated during inspiration, the patient may abruptly stop inhalation. This is called Murphy's sign, which is specific for cholecystitis. However, the absence of this sign does not rule out acute cholecystitis. Lab studies can aid in the diagnosis of cholecystitis. A complete blood count, which is routinely done, can show leukocytosis with an increase in the percentage of neutrophils. Inflammatory markers such as CRP and ESR can be elevated as well. Additionally, blood cultures should be obtained if there is suspicion of biliary sepsis. When there is clinical signs and symptoms of cholecystitis, the best initial test is to perform a right upper quadrant ultrasound. Findings that are suggestive of cholecystitis on ultrasound include gallbladder wall thickening, gallbladder edema, and pericholocystic fluid due to congestion, presence of gallstones, distension of the gallbladder due to obstruction, and possible air within the gallbladder wall in emphysematous cholecystitis. This is an image of an ultrasound of cholecystitis showing gallbladder wall thickening secondary to inflammation. While not present in this particular ultrasound, another finding associated with cholecystitis on ultrasound is pericholocystic fluid, or fluid around the gallbladder. When ultrasound is inconclusive, the next best step in diagnosis is to perform a hepatobiliary immunodiacetic acid scan. In this test, a radioactive tracer is injected into the patient, which is taken up by hepatocytes and excreted into the bile. The tracer is then able to be visualized wherever the bile is able to go. Therefore, if the cystic duct is patent, the bile enters the gallbladder and can be visualized due to the tracer. If there is no visualization of the gallbladder after more than 4 hours from tracer administration, it indicates blockage of the cystic duct and hence cholecystitis. This is an image of a normal HIDA scan showing the tracer entering the gallbladder with the bile. Notice that in the initial images at the top, the gallbladder has not taken up as much tracer, so it is not as obviously visualized as in the later images. In acute cholecystitis, blockage of the cystic duct prevents gallbladder visualization as above. Management of patients with acute cholecystitis starts with supportive care and empiric antibiotic therapy. Supportive care includes NPO or nil per os, meaning nothing by mouth, IV fluids, electrolyte repletion, and analgesic therapy. Empiric antibiotic therapy with metronidazole and ciprofloxacin or piperacillin tazobactam should be started as well. Patients who are low risk for surgery can be scheduled for early laparoscopic cholecystectomy. Early laparoscopic cholecystectomy is performed within the same hospital admission within 72 hours from the acute episode as long as it is less than 10 days from symptom onset. Patients with high surgical risk can be treated with delayed laparoscopic cholecystectomy, which is usually performed 6 weeks after the acute episode. Cholecystitis, if not managed, can lead to gangrenous or suppurative cholecystitis, which is associated with higher surgical risk and infection. The edema, congestion, and distension of the gallbladder, if left untreated, can also lead to perforation and subsequent peritonitis. which has a high mortality. Repeated episodes of cholecystitis, which has gone unmanaged, can lead to chronic cholecystitis, which in itself is a risk factor for gallbladder carcinoma. Additionally, the inflammation in the gallbladder can lead to fistula formation with the adjacent intestines, especially due to pressure necrosis from large gallstones. This can lead to the passage of stones into the intestines and subsequently cause obstruction in the intestines, leading to signs and symptoms of ileus. This is called gallstone ileus and can present with symptoms of bowel obstruction. Patients with a cholecystoenteric fistula may also have bile acid diarrhea due to excessive amount of bile acids present in the colon. This is an ultrasound of a cholecystoenteric fistula showing how gallstones can pass into the intestines. This passage of gallstones into the intestines can lead to a mechanical small bowel obstruction. It is also easy to appreciate in this image that the direct connection between the gallbladder and the intestines through the fistula could allow bile acids to be secreted directly into the intestines, leading to bile acid diarrhea. A 42-year-old female presents to the ER due to a dull achy pain in her right upper quadrant for the last 3 to 4 hours. She also mentions that the pain radiates to her back and right shoulder. On physical exam, it is noted that the patient is overweight and has tenderness in her right upper quadrant. Based on her presenting symptoms alone, what is the next best step in figuring out this patient's diagnosis? A 42-year-old female who's overweight presents with dull, achy right upper quadrant pain. The pain radiates to her back and right shoulder, and there's tenderness in her right upper quadrant. These symptoms are highly indicative of biliary colic. Additionally, the patient is in her 40s, overweight and female, all of which are risk factors for cholelithiasis. The initial step in diagnosing cholelithiasis is a right upper quadrant ultrasound. If the ultrasound were to be non-diagnostic, then the second step would be an MRCP. Next, we'll be discussing acute acalculous cholecystitis. In this topic, we'll be covering the definition, pathophysiology, risk factors, clinical features, diagnosis, and management. Of note, most of the features of this disease will be similar to calculous cholecystitis. Acalculous cholecystitis is the inflammation of the gallbladder that is not caused by gallstones. Some causes of gallbladder inflammation not related to gallstones include biliary sludge and hypoperfusion of the gallbladder. While the pathophysiology of acalculous cholecystitis is not completely understood, it is thought that biliary stasis and gallbladder hypoperfusion can lead to the inflammation of the gallbladder. As the gallbladder remains inflamed and potentially becomes distended, the gallbladder tissue can become necrotic. Risk factors for acalculous cholecystitis are related to states that lead to biliary stasis and gallbladder hypoperfusion. Total parenteral nutrition can lead to biliary stasis and hence is a risk factor. Patients who are critically ill are also at risk for this disease since multi-organ failure and shock can contribute to hypoperfusion of the gallbladder. Severe trauma or burns, CMV infection, immunodeficiency, and prolonged fasting and malnutrition are some other risk factors for acalculous cholecystitis due to biliary stasis and the potential for opportunistic infections in some of these conditions. The clinical features of acalculous cholecystitis are very similar to calculous cholecystitis. Patients with acalculous cholecystitis are usually severely ill and have multiple comorbid conditions that may mask the symptoms of the disease. For the diagnosis of the disease, laboratory studies can show leukocytosis and an elevated CRP. A RUG ultrasound shows similar findings to acute calculous cholecystitis, such as gallbladder inflammation, distension, and pericholecystic fluid, but there will be an absence of cholelithiasis and there may be biliary sludge present. This is another image contributed by Amboss that will allow us to highlight several important features of acalculous cholecystitis. This ultrasound of acalculous cholecystitis shows gallbladder wall thickening in red and biliary sludge in green. Notice that there are no gallstones present in this image. Treatment of acalculous cholecystitis mainly involves supportive management to resolve the acute episode. These interventions include keeping the patient NPO, adequate IV fluids, analgesics for pain control, and empiric antibiotics. Patients who are low risk for surgery can undergo emergent cholecystectomy. Patients who are at high risk for surgery and have multiple comorbid conditions can undergo percutaneous cholecystotomy or drainage of the gallbladder. However, if there is evidence of necrosis, gallbladder perforation, emphysematous cholecystitis, or if the patient is not improving with drainage, then the patient will require emergent cholecystectomy. A 78-year-old woman is evaluated in an intensive care unit for right upper abdominal pain for the past day. She was admitted to the ICU 3 weeks ago due to acute decompensated heart failure with left ventricular ejection fraction of 10%. Her past medical history includes 2 myocardial infarctions and GOLD 3 chronic obstructive pulmonary disease. Her vital signs include a temperature of 39 degrees Celsius, blood pressure of 125/75, heart rate of 115, and respiratory rate of 15. Physical exam reveals inspiratory arrest on deep right upper quadrant palpation. There is no rebound tenderness or abdominal rigidity. Right upper quadrant ultrasound reveals thickened gallbladder wall with pericholocystic fluid but no gallstones. Common bile duct is of normal diameter. Which of the following is the best next step in the management of this patient? A. Emergent cholecystectomy. B. Percutaneous cholecystotomy. C. ERCP. Or D. HIDA scan. This elderly woman complains of right upper abdominal pain for the past day. She was admitted to the ICU 3 weeks ago due to acute decompensated heart failure with a very low left ventricular ejection fraction of 10%. Additionally, she has a past medical history of 2 myocardial infarctions and GOLD3 chronic obstructive pulmonary disease. Prolonged ICU stay and all these comorbidities increase her risk of acute acalculous cholecystitis. Physical exam reveals inspiratory arrest on deep right upper quadrant palpation. This sign is known as Murphy's sign and is indeed suggestive of acute cholecystitis. Right upper quadrant ultrasound reveals thickened gallbladder wall with pericholocystic fluid but no gallstones. Absence of gallstones along with classic radiographic signs of cholecystitis confirms the diagnosis of acute acalculous cholecystitis. This patient is at high risk for surgery due to her comorbidities. Therefore, the best next step in management of this patient's acalculous cholecystitis is percutaneous cholecystotomy. So the correct answer is option B. Again, here's a slide reminding us of the management of acute acalculous cholecystitis. Pause the video, take a moment to consider this slide once more. Let's discuss why other options are incorrect. Option A is incorrect because this patient is at high risk for surgery. Therefore, cholecystectomy can compromise her clinical status even further. Option C is incorrect because endoscopic retrograde cholangiopancreatography, also known as ERCP, is used for cholelithiasis and acute cholangitis. This patient's common bile duct is of normal diameter, making both cholelithiasis and acute cholangitis less likely. Finally, option D is incorrect because HIDA scan is used when right upper quadrant ultrasound is equivocal or indeterminate. This patient's ultrasound clearly shows the signs of gallbladder inflammation along with no gallstones. Therefore, there is no need to perform HIDA scan. And that concludes our lecture on cholelithiasis, acute cholecystitis, and acute acalculous cholecystitis.